for joining us here on this beautiful Friday morning. My name is Tanae Franklin, and I have the honor of being your moderator for this wonderful discussion that we're going to have today regarding health equity. Before we get started, I'd like to just take care of one very important housekeeping issue, the restrooms. So for those of you that have not been in this auditorium before, if you exit either one of these doors and walk all the way down the hall to your left, you'll see both the ladies and the men's restrooms. As a reminder, no food or drinks in the auditorium, except for the panelists up here, in case throats get a little dry. But that being said, please open your minds and your hearts. And we are looking forward to learning from you, as well as our panelists, about things that we can do to improve our community. So let's get started by bringing up Dr. Bill Paul, who is going to frame our discussion for today. And Dr. Paul did not want me to do an introduction, so I'm not going to. But Dr. Paul, thank you for being here, and thank you for helping to make this possible. So please come on up.
Thank you, Tanae. Can you hear me? I feel like I have to have my head right next to the microphone, and he said I don't, so I don't. Welcome to the Healthy Nashville Summit. Thank you all for being here. Thanks to the committee who helped put this together. There are a lot of thanks to go around. The topic of the summit, and I'll get into that a little bit, we'll all get into this quite a bit today, is equity in health and advancing equity in health. And as we thought about equity, this quote kind of stuck out to me. Our history is written in our bodies, a cascade of advantage for some, a pileup of risk for others. And as we think about that, we also think about, well, why are we coming together? What are we actually going to get accomplished today? And my job in the next 5 or 10 minutes is to just kind of talk about where we've been with this Healthy Nashville Summit process and the Healthy Nashville Leadership Council, and where we're going, and sort of get us kicked off. The path to today from a health department standpoint or from a Healthy Nashville standpoint is kind of a long one. In 2003, Healthy Nashville was formed, and the first community health assessment using this MAP process, mobilizing for action through planning and partnerships, was conducted. In 2010, people were talking, and from way back from 2003, we were talking about healthy eating, active living, preventing obesity, and it felt like we were making slow progress, but not as much progress as we could as a community. In 2010, we had a Healthy Eating, Active Living Summit, and we called it kind of a convergence conference, where we had all these different threads in our community that were working on making conditions healthier for people to eat healthy and to be active throughout Nashville. And so we came together in 2010. It's been an annual conference since then, and we had the Communities Putting Prevention to Work grant. There is CPPW and additional Healthy Eating, Active Living summits, and the Nash Vitality campaign is a part of the CPPW grant. In 2013, with the Healthy Nashville Leadership Council, we launched the second full Mobilizing for Action through Planning and Partnerships assessment. And that was a big process, and I know that we've got some Healthy Nashville Leadership Council members here in the room today, and very appreciative of their commitment, because this was really a deep look at Nashville's health and a strategic look from very different angles about what do we need to pay attention to in Nashville's health as we look at the next 5 years. And through this process, the Healthy Nashville Leadership Council developed a community health improvement plan, and our summit last year was really instrumental in developing this plan. We sometimes call it the CHIP. Healthy Nashville Leadership Council put together this vision statement, and you think about this is before we did all the plans, before we decided what was important. Healthy Nashville Nashville has a culture of well-being where all people have the opportunity to, and support to thrive and prosper. It's a big vision, but that's the vision of our Healthy Nashville Leadership Council for our city. And there's a lot of talk been going on lately about the culture of health, and I've been trying to promote this idea of a culture of health, but Robert Wood Johnson Foundation has, and a whole bunch of other people are talking about a culture of health. When I talk about a culture of health, I use an analogy of Nashville. Have you all been to Lower Broadway? Okay, Nashville's Music City, and there's like all kinds of decisions and all kinds of strategies to reinforce that this is Music City. When you land in the airport, there is live music in the airport. When you go to Lower Broadway, every door has live music coming out of it. In fact, there's metal boxes on the corners that are piping music at you. And in the schools, the music industry is supporting music education in the schools, but it's decision after decision that are made in our community to make us Music City. So the idea of a culture of health is essentially doing that for health. We are actually, the healthcare industry is bigger than the music industry in Nashville. And what if we, as a community, made decision after decision that slanted towards better health for the people of Nashville? And that's kind of one of the ways to think about promoting a culture of health. And so we have seen some change. I was just talking to Tracy Buck, and she needs a special shout out. She's been with this process for 6 years. This is the 6th Healthy Nashville Healthy Nashville Summit, and here she is in the back of the room. Yay, Tracy. And Amanda Hoover, who was instrumental in planning this conference, and of course the committee. I was going to do that later, but I just saw you walking in. It's really creating healthy conditions everywhere. And when we're successful, healthy behaviors and habits should just be normal. They should be obvious. They should be effortless. It shouldn't be something special and extra to be healthy in our community. So that means that health can be woven into the decisions and the policies. And we have this buzzword, this concept that we're working on called health in all policies. But there's a thread in there that if we don't remember it, we won't succeed, which is inclusion and equity being a fundamental part of this. And there are pictures here that demonstrate some of the progress. I think 6 years ago, or 5 years ago, I guess it is, we were talking about complete streets, and it seemed like a radical idea. And it was one of the recommendations out of this conference. Now, it wasn't solely this conference that pushed the idea of complete streets, but this conference helped connect in people's minds the notion of health with how we build our streets in the city. Breastfeeding, we've seen great progress in breastfeeding because of trying to go to the hospitals and make changes so that breastfeeding is normal as opposed to something special. I could go through all of these. Our new buildings, we're excited about. It's an example of building something, making decisions about the health of the people who are going to use that building as you build it. So a lot of times we think about health as white coats and doctors and stethoscopes and hearts. In fact, if you do a Google image search on health, that's pretty much what you get. But we all know, if you're here in this room, that health is bigger than that. And the World Health Organization describes health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So once you start talking about health in that way, then it becomes kind of ambitious, but it also becomes imperative that we go beyond healthcare and talk about all the things that determine our health. And one of the things that's very evident in Nashville is that place matters, that your zip code really is a big predictor of how your health is going to be. This is a map of early mortality, and the bigger purple spots are places that have higher rates of early mortality. And the darker red spots are the places that have higher rates of poverty. And we have some neighborhoods in Nashville that have very low rates of early mortality, and others that have very high rates of early mortality just within our own community. And this kind of stands out, and it's something that we can't forget. Paying attention to what really shapes our health. you know, we often think about health as in terms of the top of the pyramid, more counseling, more education, more clinical treatment. Those are very important. We can't neglect those. But in the world of public health, we try to move down that pyramid, and we love immunizations because they last a long time. We love things that kind of change the default, change the environment so that the normal automatic default choice is a healthy choice. And you can see that that's not a new idea. We fluoridate water. We make sure restaurants are safe rather than tell you it's your responsibility to avoid salmonella in the restaurants. But where health really begins is in our socioeconomic factors, education, safe housing, employment, access, and equity. When the Healthy Nashville Leadership Council looked at what Nashville really needed to pay attention to realize its vision, these are the three things that we came up with. Maximizing the built and natural environments to optimize health, and hopefully you see some of that in Nashville, with bike lanes, with greenways, with parks. Supporting mental and emotional health. I know that the representatives of both Vanderbilt and St. Thomas are here. They did their health assessments, and mental and emotional health rose as a priority there. And the Chamber of Commerce published something this week, and mental health rose as a priority there. So this is obviously something that's got to be on our community's agenda. And then finally, but actually highest priority for Healthy Nashville, was advancing equity in health, and that's really why we're here today. So the charge for today is to improve our understanding of equity and inequity in health, to develop and strengthen a strategic focus on equity in health. That is to really think about all of our different organizations, our different lives, and to figure out how to be more strategic and how to move the needle on equity in health. Make connections across organizations and person to person. And this has been one of the bullets at every Healthy Nashville Summit, which is get better at turning vision into reality. On one level, we're getting together and we're talking. On the other hand, we all want to see results. We all want to see results at Nashville. We want to see Nashville become a healthier place. And so that's part of the goal of today, is to go from talking about equity to what actions can we really take, and what actions shall we take. So that's all I have for you. Again, I want to thank the Planning Committee, the sponsors, and everybody who's going to participate today. And I would thank all of you for being here. So with that, I'm going to turn it back to Tanae to introduce our panel. Tanae Franklin from the Tennessee Department of Public Health, Office of Minority Health. Is that correct?
Yes.
Here we go.
Thank you, Dr. Paul, for starting us off today. So I'm going to ask our panelists to go ahead and have a seat as I do brief introductions. So I'm going to start with Ms. Brenda Perez. Ms. Brenda Perez is Mexican and Latina. She is 30 years old. She's an organizer with Workers' Dignity. Just 2 years ago, she was a low-wage worker in a retail store. She had been volunteering for years and became a member of the Workers' Dignity Project. She took several leadership roles and helped her fellow workers recover stolen wages. She now trains workers every day to fight for their rights and is a lead organizer with the Just Hospitality Campaign, Fight for Better Wages and Rights of Cleaning Workers. Reverend Edwin Sanders II is a senior servant and founder of the Metropolitan Interdenominational Church in Nashville, Tennessee. This congregation has attracted a broad cross-section of people with the mission of being inclusive of all and alienating no one. Metropolitan has outreach ministries in the areas of substance abuse, advocacy for children, sexual violence, and harm reduction, in addition to providing services to persons infected with and affected by HIV/AIDS through the First Response Center, which was founded by Reverend Sanders in 1992. Dr. Joseph Webb is the CEO of Nashville General Hospital at Meharry, a publicly supported community-based hospital which serves as the primary teaching hospital of Meharry Medical College. Dr. Webb joined Nashville General Hospital this year in January 2015, bringing over 25 years of proven expertise in for-profit and not-for-profit healthcare organizations. He most recently served as the Chief Operating Officer for Common Table Health Alliance in Memphis, Tennessee. So as I take my seat, we're going to have a discussion. We're going to start this panel off by having a discussion about health equity. And I did my homework. I read the report last night. How many of you all have seen the report on the website? So this is the work of Nashville that you all have done, that Metro Public Health Department has done, and I think it's fantastic work to see it all come to fruition in one place. So let me start with the panel. And in this first question, I would like for you to incorporate a little bit about what you do in your perspectives. What does health equity mean to you, and how does the work that you do affect health equity? And is there anyone that would like to start? I'll go ahead and start with you, Reverend Sanders.
All right. First, let me say thank you for the opportunity. I've actually been in and out of, I guess, these summits since their inception. One of the things that we're very much involved in doing at the Metropolitan as relates to health issues, really as relates to issues that address the quality of life for all people, is trying to advance the ways in which the conversation around these issues is dealt with, such that we don't find ourselves just moving within the parameters of what might be the statistical or the theoretical understandings that very often are the byproduct of the ways in which many of us have been trained in disciplinary terms and have been trained to look at these issues as a result of the ways in which we have been incorporated and involved in systems that very often dictate that the ways in which we look at issues fits within the parameters of that which is acceptable and that which has been qualified as the ways in which we talk about these issues. What we do at Metropolitan Church, if you walk into the doors of Metropolitan Church, the first thing you see is an image that is intended to represent not just the focal point of our faith and who and how it is that we address as a community issues related to who we are as physical, mental, and spiritual beings. But when you see that image, there are two things in it. One is it's a unbelievable representation. It's a kaleidoscope of color, which ends up as being with the intent of trying to represent the diversity of the pieces of the puzzle that we're looking at. But when you look at the image very clearly, you eventually recognize that the image is one that has embedded within it outstretched hands. And even though I could easily talk about all the theological aspects of what that's about, what I find people being drawn to and what I try to advance is that what we have to do is be about the business of stretching. Very often, because we have these well-defined boxes that represent all of the language, represent all of the jargon, represent all of the theories that, like I said, that we've been steeped in, what I'm always trying to do is push people beyond those boundaries and to understand that there's still ways in which there are issues that need to be addressed. There are problems that if we're going to solve them will require moving outside of the traditional frameworks of thought. As a matter of fact, one of our little cliches at Metropolitan Church is to not be involved in telling people what to think, but rather helping people to grow in terms of knowing how to think. There's a lot of creative energy that goes untapped in our community because the people who very often represent the potential for understanding that we have been discounted because they don't easily speak within those well-defined frameworks and structures that we have decided are the parameters for the conversation. I'm always trying to help us push the conversation beyond those parameters, and I'm always trying to help us to understand that the issues are bigger than very often put before us. For instance, and I'll stop at this point and just say it's interesting, as Dr. Paul was talking, in a specific reference to the culture of health. I would suggest to you that you cannot understand the culture of health unless you understand the culture of oppression if you're going to talk about health inequity. And the ways in which those dynamics manifest themselves very often end up being the underpinnings of the reasons why the disparities that we face are so great. So the conversation has to be bigger than just talking in the terms that normally we have felt comfortable doing in the past. So we always are trying to stretch, push, advance, and try to make sure that the way in which we address these issues is taking into full consideration all of the voices that are being affected and impacted in this community.
Thank you. Ms. Perez.
Can everyone hear me okay? I always feel like mic check is nice, but you guys did a wonderful job this morning. Good morning to everyone. My name is Brenda. I work in town with an organization called Workers' Dignity Project at times, because that's how we started over a summer in response to a lot of abuses on the job that are still happening in Nashville. The major one was being wage theft, where people were just working and not being paid. It's as simple as that is. Like, they work for a week, they work for a month, and at the end of their work cycle, they expect their paycheck, as we all do, and their bosses will tell them no. And after those reasons of telling them no, they'll give them, they'll retaliate against them. They will threaten them with police, with immigration, with their children. All sorts of things happen. And that's how I am connected to the community, and this is how I became involved as a member of the organization, and just showing up and helping people work through this process. What we do at Workers' Dignity and how we became involved in this is, as the Reverend said, we are connected with folks who are not sometimes allowed in, or sometimes not even receive the invitation. One of the things that we do is a labor rights training every month, where we talk to workers about what their rights are in the workplace, and it's quite amazing how many people don't have their workers' comp be respected. So as we talk about health today, just wanted to shift the conversation a little bit of where most people spend a lot of their time throughout the day, and it's at work, and how people's health and safety is not being respected in the workplace. One of the things that we did this summer was a survey with 53 cleaning workers all over the city. We try to catch people at the bus stops. We try to catch them before they were coming into work, outside of work, in apartment complexes. So most of the folks that we interviewed were women of color in the hospitality industry. And this was an important point to us as a city that is expanding and it's growing and it's being dubbed the IT City. How is the IT City treating its lowest paid workers? And it was quite amazing to hear, the low level of training that happens. The fact that a lot of workers don't even receive overtime, not even overtime, a lot of workers don't even receive minimum wage. That is something that is happening here. So what the organization does is really just, as the Reverend said, we find these voices and we don't teach people, we listen to folks, and what we listen, then we push forward and try to present to the city as a social responsibility. If we are going to allow people in our city to be treated this way, to live this way, to have their bodies be abused and exploited, for somebody to make lots of money and for people to live in the dark red spots and the dark purple spots, as Dr. Paul presented earlier today. So that's briefly just a starting point of where I'm coming from.
Thank you. And those that both you and Reverend Sanders serve usually seek services at Nashville General Hospital. Mm-hmm. So Dr. Webb, can you talk a little bit about what health equity means to you and the work that you do with health equity?
Good morning, first of all, and it's certainly a great pleasure to be here with you today and to talk about health equity. First of all, if you looked at the report, you saw that health equity has quite a complex definition as it relates to health inequality. But for me, it's simply equal access to health based on the needs and preferences, and as it relates to the available resources. Certainly, Nashville General, the essence of Nashville General is to address healthcare issues of those that are considered safety net, underserved. And so we do that in large volumes. The benefit that we can bring to health equity is to engage in capturing information, data, race, ethnicity, language, socioeconomic status, and try to capture that through population health framework so that we can track and monitor how well we're doing. The research shows that there are a few number of hospitals across the country that actually provide care to a very large number of ethnic minorities. And the research also shows that those hospitals that provide large proportion of care to ethnic minorities tend to have a lower quality of care. That's his research, it's not me saying that. So what we have to do at Nashville General is to be cognizant of that and to make sure that we're tracking, monitoring, and utilizing metrics that comes from the data to make evidence-based decisions on quality outcomes through our population health model so that we can make sure that we're not falling into that category of providing care that's lesser quality than what you would see in a typical hospital that serves a majority population.
Thank you. So you all know Nashville's community, you know Tennessee's community. We're doing a lot of good things in Nashville and in Tennessee, but are there things that we should be doing locally that we're not doing when it comes to addressing health equity? So where are the gaps, and where do you think we should be focusing or targeting our efforts on those gaps to address health equity? This is a conversation, so first come, first serve.
I think we need to certainly take a more rigorous approach to utilizing data in the way we identify where the gaps are, because we can be qualitative about it and use anecdotal opportunities to get out and try and do things that'll make us feel good. But we tend to operate in silos. We're protecting our resources. One of the areas that I think would be real helpful to explore is that of collective impact, identifying what are the goals that we want to achieve as key stakeholders, what are the goals that we want to achieve, and let's create that initiative that gives the resources to that focus, use what's called a spine or a backbone, properly resource it, and then get the stakeholders to the table so that we can all focus on the same issues. Because without doing that, again, we're spinning our wheels, our resources are scattered all over. We all mean well, but the data that we can collect to drive that, to make that evidence-based in the decisions that we would make, utilize that to the maximum. We have the resources. I don't really think there's so much of a scarcity of resources. There's more of a scarcity of collaboration and a willingness to come out of our silos and work together across the lines in a collaborative effort.
Thank you.
I would agree with that. I guess the thing that I find myself focusing on and looking at a lot of times is why the silos exist and how it is that we have come to the places where collaboration seemingly is so difficult. And I think that understanding that very often has to be framed where there's a consideration of the social determinants that have been a part of what has brought us to this point. We didn't just arrive here in the 21st century, but rather it ends up being the byproduct of the 19th and 20th century realities in this country that continue to haunt us as we try to figure out how to build those collaborative initiatives. There are ways in which there is evidence of it happening on a level that gives rise to, I think, some of the more positive statistics that we see as evidence of advancements in our community. But I also think that there seemingly still is a very well-defined segment of our population that has been left out of the equation of inclusion as relates to those issues. And consequently, very often what we have, even statistically, does not translate into us having the evidence that we really need. So I think there's still a much greater initiative around the ways in which evidence is sought and the ways in which it is considered. There's a very interesting study recently that AMFAR, one of the historic organizations that's dealt with HIV and AIDS, that was done by Greg Millett. And one of the things that Greg did that I found to be very interesting, because it's almost a taboo subject in terms of research, and particularly biomedical research, is that somehow there are factors that go beyond the dynamics that we find ourselves easily being able to understand that seem to be driving our problem. When I look at the Minority Health Initiative around HIV/AIDS, for instance, and some of the other similar initiatives that go beyond HIV, one of the things that you see is that there has been resource directed in those places. And I think this is a little bit of what I hear Dr. Webb saying. It's not that the resource isn't there. One, it's where the resources are directed and whether or not we actually are impacting the communities and the institutions that have the commitment and have been positioned in a way that allows them to perhaps be most effective in responding. If indeed you look at the map code zipping, the zip code mapping kind of analysis that Dr. Paul was doing a little while ago, it's, you know, my children have this thing. I don't know if any of you have children that do this. Every now and then, my children will look at me and go, "Duh," what is there about this that you don't understand? I mean, you know, it's clear. I mean, it doesn't take much to know that the zip codes that represent the greatest points of difficulty as far as the disparities are concerned are zip codes that end up being populated by people in many instances who have been blessed in one way or another with degrees of melanin that allow their presence to be easily identified and seen. So what I'm suggesting to you is that we have to be clear. And I'm going to just push it a little further on that point, right? You know, we spend a lot of time very often not dealing with what I think is at the heart. I don't want to go too quickly. My wife gets me all the time about being the talker who'll start something and then not finish it. I want to go back to this position that Greg Millett advances. What he says is that when we look at the ways in which racism has become systemic, institutional, and structural, that perhaps even within the arenas where the research is being done, that the process is tainted such that the outcome gives results that would suggest there are ways of solving the problem that do not necessarily include those persons who are most disproportionately impacted by the issues we're talking about. I found, I don't know if any of you saw 3 weeks ago, the New York Times Magazine article that talked about why we need black doctors. And one of the things that you have to realize is that you do need more and more people who have sensitivities and have awarenesses that allow sometimes to be more effective. Now, people who look at the sciences very often say the disease is a disease, the problem is the problem. It's, we've defined it, we've isolated it, we've seen it, it's in the data. But the fact is, that's not enough. So one of the things I would suggest we need more of in our community is, we have all these different things. We have cultural awareness, cultural sensitivity, cultural competence. I'm sure everybody in this room has been to one of those groups. The term I like to focus on a lot these days is cultural humility. Cultural humility is when you have the wherewithal and the nerve to say you don't know. Because very often people who have been steeped in understandings of cultural awareness, competence, and sensitivity are people who think that that gives you license then to be able to address the problem in its most effective way. I don't know is something that a lot of us find ourselves hard put to say. We think we know, and we have built our work around agendas that suggest our objectives are born out of something that is measurable and understood in ways that are not compromised by other factors. But the thing is, we don't know. Let me just say one last thing about your report. Okay? Because I want this to be a part of the conversation. Okay. It was interesting to me that the section on discriminatory beliefs, I found it interesting that it wasn't called discriminatory facts. Because there's a way in which sometimes beliefs ends up being a way in which it's almost a coded way of de-emphasizing the ways in which there are facts that speak to the reasons why these problems exist.
So reframing the issue, sort of how your perspective. So, yeah. Ms. Perez, the work that you do, you don't need data. You don't rely on data. You have that duh moment all the time, right, in your work. So could you respond about where you see things that we should be doing locally?
Yeah, there's a huge lack of accountability to employers. It's as simple as that. If we're looking at these communities, and then we can pull up data on what kind of jobs these communities are doing, but in general, there's just a lack of accountability. We talk to people who are cleaning hospitals, and they don't have access to health insurance. And they're not only putting their bodies at risk, they're putting their families at risk. There's a lot of workers who go out there without any training. There's some workers who go out there who have to buy their own safety equipment. And we're talking about people who are cleaning hotel rooms, who are also doing construction work, physical, hard labor. It's like, if I'm sitting in an office, I'm okay without having gloves, I'm okay with that. But this is not the work that's happening out in our community, and that's not how people are being treated. And it's happening all across Nashville. The Nashville Predators, I've gone through several name changes since my 15 years here, but we're the arena. We come across workers who are working their third shift making $7.25. So you're working third shift, you're away from your families, you don't have transportation to get there. People are sitting out on the sidewalk for hours waiting for a family member to come pick them up. And it's kind of ridiculous that we allow employers to treat our people that way, to treat our Nashvillians that way. We can, if we're going to raise the bar, I think what you're saying is we don't need to raise the bar here. We need to raise the bar from those people that are way over there on the other side and have been, disconnected. So I think that's one of the major things that we are working on with low-wage workers here in Nashville, is that lack of accountability on employers. It's not happening. We're having multiple projects come in through the city, government-funded projects at times, and there's no access to health care, to these folks. And at times, even when they have workers' comp injuries, they will be intimidated or threatened. As simple as like, okay, well, I don't think you actually got injured like that. I think you came like that from work. Oh, okay, And if you, we've had bosses tell people, okay, well, if you go to the hospital, I'll make sure to, let the police know where you live. And we're talking with folks, of different shades of beautiful skin, who a lot of times are also under police intimidation by being on probation of their immigration status, right? And it's like, okay, well, maybe I did fall, maybe I did have a nail go through my finger, but it's nothing that I can cure at home or bandage it up, and come to work the next day. Because a lot of times these same workers are not having paid sick days, right? So you take a day off work, you're not paid for it, and then you lose wages, and you're already making $7.25 an hour. So to talk about access to health care and health equity, we also have to talk about what people are doing with the other time, and if they don't have ways to do this, and they're being put barriers on this. This is where we're coming from, and I think as a community involved in many sectors of work here and many representations, I think we need to look at how our people are being treated in the public and the private sector, and honestly, like who cleans the office where you work, and do they get health insurance? I'm not sure if anybody
Thank you. So when we think about health equity, we're coming from it. The Metro Public Health Department is hosting this. Robert Wood Johnson, Center for Policy at Meharry, is one of the contributors. We think of public health, right? So what is it regarding public health? What is public health's role when it comes to health equity? And I find it interesting that thus far, no one has focused on health behaviors. You've focused on social determinants of health, you've focused on data, but not really those individual health behaviors. So talk to me about the role that public health has. What is our take-home message regarding public health and how it affects health equity?
I want to just mention that Dr. Paul addressed policy, and he said health should be included in all policies, something to that effect. I think that's the underlying driver of all of our activities in the community as it relates to access. There's a need to engage our particularly local policymakers in addressing actions that will create guidelines. The points that you mentioned just a moment ago about the employer responsibility. Well, if there's not a policy in place to cause that to happen, it's not going to happen. So I go back to even through the public health department, what we should be looking at there is engaging them and providing us with real information about outcomes, empirical data. That should be the driver of policies. You can't affect health equity without first impacting the distribution of social determinants in the community. And if you don't recognize what those social determinants are that drives that health-seeking behavior, then we need to be spending some time delving into that, particularly as it relates to the most at-risk populations. There's 75% of our healthcare spend, by the way. We're closing in on 20% of the gross domestic product in healthcare. 75% of our healthcare spend is on treating chronic conditions, which means that as you look at the older population, that's where a lot of your spend is going to be. As you look at that population, if you further stratify that and look at the distribution of social determinants, then you're going to see an exacerbation of that cost within that population. How are we addressing that? What types of policies do we have in place for addressing the older, ethnic, minority population in our community? Healthcare has become not just an issue, a social issue. It is very much an economic issue, and it is in our community. I read some of the information in the report about, at one time, Nashville had the poorest health care for a certain population of people, and that was kind of the motivation of the Harry Medical College coming into existence. Well, it's come a long way, but we still have situations where infant mortality and just mortality rates, and there's research that's been shown that shows that if there was a comparable relationship among the races and ethnicities as it relates to mortality, infant mortality and adult mortality, then something like, the research was a few years back, but it showed about 800,000 lives could have been saved. Now, disparities, on the other hand, as it relates to the economic environment, there was a study done between 2002 and 2006 that showed that somewhere in the neighborhood of $229 billion could have been saved if disparities that existed among Asian Americans, African Americans, and Hispanic Americans, if those disparities could have been eliminated, the number was somewhere in the neighborhood of $229 billion could have been saved. Now, that's what the Affordable Care Act is all about. One of the tenets or the principles of the Affordable Care Act is starting to bend that cost curve in healthcare. And the other is to create a more integrated delivery system so that we can start to address the disparities and the inequities in healthcare. And I just want to say this, it's not all about race. There's a 12%, research shows that 12% of this country is health illiterate. Mm-hmm. Now, if you were to further stratify that and look at the social determinants, you'll probably find that there's a significant exacerbation of that number as it relates to certain populations. So health literacy is a big driver of the cost, of the inequities. Cultural competency is a big driver. And by the way, cultural competency does not always relate to a white person not understanding the culture of the African American population. There are African American doctors who don't understand the nature of the culture of that population or the Hispanic population. So it runs deep. Unfortunately, it's not just simple enough to say that it's a race thing, because it's not.
Thank you.
You might have noticed when I started, one of the things I said in relationship to the question of a culture of health, when I made reference to the culture of oppression, I think that's a part of what allowed you to be able to do exactly what you say. Because you talk about a culture of oppression, then you talk about the ways in which classism and sexism and all the other isms and homophobia and the like end up being a part of the equation. But I think that what you find is that very often there are ways in which you can look at particular identifiers in terms of persons within community. And I think I heard you say the exact same thing, that end up still representing a disproportionate part, of those numbers. But I couldn't agree with you more in terms of the whole question of health literacy, because in many instances, I know, especially when we're dealing with infectious disease, it's just not there. Let me just say one more thing, though, in terms of public health. Again, that's another one of those points at which I don't know, and I must admit now, you know the arena I live in and the way in which I do my work. So you're always going to have to hear some anecdotal activity, okay? But let me put it to you like this: when I was growing up, the health department had to be one of the most stigmatized places you could be a part of. You know, if you went to the health department, it usually meant you had something, and very often that assumption was something less than the positive, right? But I would say that one of the things we still are dealing with is the ways in which we create perspectives of the institutions that help us with public health. And one of the problems that we have as far as the effectiveness in terms of implementing public health strategy has a lot to do with distrust. It has a lot to do, especially in our communities, that very often, as you were saying, are most disproportionately impacted. It has to do with what I refer to sometimes as dysfunctional belief systems. There are a lot of anthropologists who've done ethnographic studies that have just dealt with no more than the language of people who are disproportionately impacted by disease. And what you said is 100% true. I mean, it turns out to be the case that it has to do with a certain level of health illiteracy and where there's a lack of health literacy. But when you listen to what people say in terms of what ends up being the barrier between them effectively taking advantage of what is available, it very often is the byproduct of dysfunctional belief systems that will, you know the language. It's the language of I'm not taking this, you're going to die from something. I'm not taking this. You know, there are people who've done very good studies that demonstrate the degree to which this ends up being the evidence of what you're saying. But what I'm suggesting is that all of us in the community, and I agree 100%, have to become literate in a way where we understand how these dynamics manifest themselves, such that whenever we have the opportunity, when I hear public health, I'm going to tell you two things that always come to mind. You know, it's like when I've done tons of work with CDC, right? The first thing that comes to my mind if you say CDC is the word surveillance. If you say the word surveillance and the ways in which it's very often implemented and carried out in our communities, it instantly breeds distrust and fear. And one of the things we have to do is educate our community in a way that allows those hurdles to be overcome. Even the ways in which our institutions that very often are best postured to provide the responses that we need, the dysfunctional belief systems that sometimes cause us to look at those institutions as being less than, inferior to, and the like. And I think one of the things we're always struggling to overcome is the ways in which those historical stereotypes continue to haunt us, even when there is, I think, clear evidence that without those institutions, including Meharry and others, you know, like the numbers that you referred to as carrying a disproportionate burden as far as who delivers the services. A lot of times, location as well as identification with certain communities translates into the ways in which people end up being reluctant or fearful. So, and the trust factor needs to be addressed in a very significant way. We have to build trust. And and let me be very clear, I hope I don't sound like I'm being dismissive or I'm being somehow not appreciative of the ways in which the scientific and the clearly well-developed, objectifiable systems of evaluation and assessments are done. What I'm saying is kind of what I'm suggesting Millette says. It is not enough. And again, I go back to my initial point about how we have to stretch ourselves in terms of our understandings that allow us to perhaps get to the things that still are in the way. Okay.
So Ms. Perez, talk to me about your grassroots perspective of how public health plays a role in addressing health equity.
Yes. It's interesting to hear these perspectives because I come from a different place where people's rights are not being respected to begin with, right? So in order to even get a place where they're even seen or put on the map, so it's interesting because this is a question that I've been thinking about because we have, laws and policies in place that are supposed to protect workers on the job, like workers' comp, but employers are shifting the responsibility by hiring subcontractors and bringing people in, as a third-party employer, and then they get hired, and therefore these large corporations are not, they're not their direct employer, so they don't provide any of these benefits. So thinking of how public health can kind of support these workers who are doing these jobs, who are not being taken care of and their bodies are being exploited, to have that access, it's almost like we're missing 3 steps in the middle of that, right? They have public health, they can go to the clinics there, Nolensville Road, Murfreesboro Road, people know, Matthew Walker, it's like, I think within the first week of moving to Nashville 15 years ago, it was like, Matthew Walker is like, know that, that's where you can go get taken care of if anything happens to you anywhere. They will take everybody. And it was super important that it was in a historically Black neighborhood. It's like, okay, we see who takes care of who, right? It's not a clinic I can go to Green Hills, per se. Nobody sent me there. So thinking that this is where people have on their off time, they have these clinics that will take care of them, but then where they're at work, they're being disconnected and being told not to, okay, you're not getting injured here, that's something you brought here. Or they'll find reasons for people to get fired. There's something missing here, and to identify that and to work through that, I think would be really important, whether it's a social responsibility on employers, whether Nashville as a community states okay, we want to make sure that people have a living wage in the X amount of years. We want to make sure that we at least know what the names of the workers that are doing government projects. We at least, right now, I don't think we have an actual tally of the people who do, the Music City Center, We worked with a group of people that didn't get paid $18,000. Subcontractor was out somewhere in South Carolina, and this is government money, and they don't know who is working there, so they don't know how people are being treated. They don't know if people are getting injured on the job. And by they, I guess it's we. We don't know that. So kind of figuring out how we bridge these worlds, because I think as working class folks, we are out there in the community, we're taking care of our families, and then we're in our workplaces, right? But what we do in one affects the other, and how to have those be connected and have that responsibility put on the employer to make sure that they're being respected, that the rights that we have now are being respected and being valued and being taken care of, and then how do we raise that? I think goes to shifting the language, right? Going to the communities, being involved, and understanding the community's beliefs of healthcare, right? Because when you're raised in a culture of not having healthcare as a child, or you only go when it's really bad, when you can no longer have it, when you've gone through all of the Tylenol, what does that mean when you just show up like that? When you haven't been to a doctor in 5 years, when you don't go to the dentist unless you're in incredible amounts of pain, what does that mean, and how do we talk to people on their terms? I think it's something. I think we have I think the illiteracy could be on them, but it could also be put on us, and we need to learn that language.
So my last question before we open it up for dialogue with the audience, let me say this. Earlier this week, I had an opportunity to visit Johnson County, which is the home of Mountain City, Tennessee, far east corner of the state, Appalachia, right? Yeah. Probably low health literacy rates as well, definitely low income, very few resources. But I was struck by the fact that that community pulled together to take care of everyone in the community. So there were people that they called, that they knew how to call just to get things done. So we're in Tennessee, volunteer state, and we come together in Nashville around the floods, helping each other out. So I want to talk about our role, or the role of nonprofits and private sector companies to come together. How can we work together with private sectors and nonprofits to address health equity? Now, I know we've talked a lot about employment. We know that that's one of the areas of policymaking that we can start. But what else can we do with other entities in terms of collaboration, Dr. Webb, that you spoke of before?
Well, I will go back to the issue of collective impact. Health equity is a social challenge, And if you'll look at where most impact has been made through utilizing that format, it's a very rigorous format. It's not just a term that's used loosely. There's, again, it's deeply rooted in empiricism, but the beginning point is that you bring the stakeholders together around this social issue. You create proper scope, and then you add the resources to that initiative so that it can be driven as a vehicle, and these individuals will make a commitment, these stakeholders will make a commitment and agree on it is a social issue that needs to be addressed. It is something that we're willing to put our resources behind. We will create a spine for it, and we commit to resolving this social issue within our community. A large portion of health equity falls within the area of behavioral health. And I spent some of my years in administration operating behavioral health hospitals, and we have a significant challenge here. It is a social issue. It is an equity issue as well. And at some point, we're going to have to start to move these individuals into a more appropriate setting. Nobody decides that they want to live on the streets just because it's a cool thing to do. Most people that do that have behavioral issues. They're either not on medication, they need to be on medication, they're undiagnosed, but they have mental illnesses. So that's just a part of the health equity issue that we've kind of left out here today. And if you were to drill down into that, you'll probably find there's still social determinants that will exacerbate that as well. But it all goes in there. I know we're running out of time, so I'll
Yeah, I mean, we're good on time, so, but
okay.
Reverend Sanders, we can't have another 10-minute answer.
Well, let me tell you a comment I often make. let me give you a comment for that. One of the problems in solving these issues is the soundbite mentality in our society. That if you can't say it in a soundbite, somehow it's dismissed. The fact is, it takes something more. We're talking about issues that if we could answer them in sound bites, we wouldn't be sitting here today with the issues being as disparate as they are. So you have to forgive me for realizing.
Message received.
Yeah, when I look at audiences, I look at them very much to see whether or not there's a clear sense that they're getting what's being said. And so sometimes I forget to look this way until I've already been talking 2 or 3 minutes. So if you hear me talking and you want me to be quiet sooner, you can either nod. You can also say, and I'll deal with that, And if you really feel like it's hitting you right, you can say amen. All right, go ahead.
Did you have something else you wanted to say, Dr. Webb?
Yeah.
No, I'm fine on that issue.
Ms. Perez?
Yeah, I think if we're thinking of the Nashville health sector role in general, I think, the healthcare industry is large in Nashville, right? And we have a really wonderful opportunity to show what it could look like if the headquarters are based here, and we could be a wonderful example of what taking care of our community is, right? Because this is kind of what it is. We want to make sure that everybody in all aspects and all corners of the county and beyond, are taken care of, and taken care of in a way that meets their needs and not meets our needs and our language and our, and how we want to present it, right? But that they are actually taken care of. I think there's lots of opportunities. I know I said this before, but I just, when I literally meet people who are cleaning hospitals and picking up needles and don't have health care, it just shocks me. It just shocks me. And I know it exists, and even when I hear more about it, it still just takes me back. Like this is something that we are currently okay with.
Yeah.
We are okay with this, and I think there's opportunities to have like the healthcare industries and the public health to make sure that everybody on all spectrums are taken care of. That there's this disconnect that somebody who takes out the garbage is not less of a human, therefore does not get the same benefits that you do, or that we do, or that I do. I think that we have a really wonderful opportunity to set an example of what taking care of our people is through the private sector. If we think of these hospital corporations as part of us, and part of our people are working there and having that responsibility put on them.
I would have to say that if you dealt with, and this might be ill-founded in some ways, but if you had to say to folks, is the healthcare industry in Nashville driven by the intent to address the needs of the people in the communities that you're talking about in terms of employee exploitation, and the communities that we're talking about in terms of that zip code mapping analysis? If you ask the question, do you think they're in business in order to deal with the issues of health disparity and solving those problems, over against, are they in the business of profit? First, I think most in this room would understand that the issue of the profit is much greater. You look at, I always call Nashville, especially when we're talking about going to East Tennessee. I mean, I've spent time all over the state. And one of the things that I find interesting, I sometimes refer to Nashville as a gated community, the whole city, because there's a way in which gated communities very often go through a lot of effort to make sure that they insulate themselves from what's going on around. The first thing is, I don't think we can disassociate ourselves from what's going on in the state across the board, because a lot of our problems right now could be addressed if we did not live in a state where there was a refusal to embrace Obamacare and the expansion of healthcare, right? It's even more clear in terms of what I'm trying to say about racism, because it's a driving factor. Racism runs so deep that people will respond in ways that are in their own disinterest. I mean, no one needs Obamacare more than the people you were talking to up in East Tennessee and in some of these counties where, there's a great degree of homogeneity in terms of race. So all I'm saying is that I'm agreeing 100%. It is, a lot of what we're dealing with does evolve around social issues. But when we talk about behavior, I would suggest, and I would like to try to get it somewhere put into the lexicon of behavioral science, that racism is a disease, just like we've now been able to understand addiction as a disease and the like. And that disease is destructive in a way that if indeed it is not addressed in some fashion, it tends to be a killer. I mean, so to the extent that some of the problems we are dealing with in Nashville are the byproduct of the lack of complementarity in terms of working together with the healthcare industry that's here, there's a way in which it needs to be understood. It has to be appreciated. So my simple closing point is this. All these things we're talking about, they are intertwined, they are interrelated. And there's a way in which, until we expand the conversation in this community to a point where all of these aspects, especially as I listen to, to Ms. Perez, and she's talking about, when I look at that chart, I would also tell you that there's some evidence of an attempt to have some analysis of what's going on in the Latino community. But I guarantee you, the misrepresentation of what's there is tremendous because of all the other fear factors that end up being a part of the personhood of the individuals you're trying to serve. I mean, it makes sense. And the same thing is true in other communities as well. So, I mean, I hear all these wonderful statistics about how our employment rates have gone up and how this, I would just simply say that it depends on who's doing the looking where they're looking, and what they're trying to prove. Because if you want to continue to prove that you are the it city, if it translates into, it's easy to get dismissed around Nashville. I always tell people Nashville is the only major metropolitan area in the Southeast where there are the issues of racial parity do not end up being a part of the politics. There's a whole history. You need to go back and look at why that's the case, not the least of which is the fact of metropolitan government. But we have to deal with that. And so it's a both and, okay? And last little cliche, let the money follow the need. And if the need is in the community, which is reflected by the Matthew Walkers, the federally qualified health center that's in the community is being most disproportionately impacted. If the need is at Nashville General, then the issue ends up being to make sure that the resource and the money follows the need.
Thank you. So now we're going to open it up for questions and answers, but we're going to flip the script a little bit. Yes, there will be an opportunity for you to ask our panelists the questions, but I would like to start by allowing our panelists to pose a question and let someone from the audience respond. So while you all are getting your questions together, I'm just going to take a few seconds and just share my take-home messages that I heard today in our panel. Employment policy to avoid discrimination, utilizing data, cultural humility is a new term that I'm going to borrow and start using. 12% of our country is health literate. Collective impact, which is a much stronger term than just collaboration. And then lastly, approximately 75% of our dollars go to treat diseases. So that leaves very little resources for us to focus on primary prevention and public health, making sure people don't get sick in advance, right? So that being said, I'm wondering if anyone up here has a question that you're ready to pose to the audience, and I'll walk out with a microphone for a response.
Just kind of have like a poll, and of course, setting a place where we can be honest with each other in public settings is hard. But just like generally speaking, I just want to see if people would be comfortable raising their hands if you have ever been uninsured or one of your family members has never been uninsured. Okay. All right, I think, so this is where we're coming from, right? I just wanted a understanding. That's the first one I have, so you go. Or how did that feel? Let's just go there. How did it feel when you didn't have access to health insurance or have access to health care?
Yeah. I could say it's scary. Thank God it didn't last long for us, but it did happen in our family. That. I just want to ask you, in terms of, are there expectations that you had in terms of what would come from your giving your time to being here this morning that have not been met? Are there questions? So I want to make sure that we didn't miss the point in what we're saying. Yes.
Hi, my name is Elisa Batson, and I'm on the Board of Public Health. I feel like one of the things we struggle with is how to communicate health education with populations in need. One of our favorite ways of communicating these days is through online media. And it seems to me that's the exact way of communicating that does not reach the populations that we are trying to reach. And the populations we are trying to reach often don't have computers, they're not on Twitter and Facebook, they do not receive our great email newsletters like Nash Vitality. They often don't even receive the newspaper or read the newspaper. And then there's the question of language. So I was wondering if you have any suggestions about how to reach populations in need with, to make them more health literate, to notify them of resources we have that they may not know of and other things.
Yeah.
So,
You know, in military terms, I hear this term a lot now, boots on the ground.
Yeah.
I think there's a way in which you have to figure out how to create a strategy that involves hands-on, face-to-face, opportunities, whether it be through social service organizations, whether it be, through community-based organizations, through churches or whatever. But that's not to be, overlooked. We had the experience here, 15 years ago, of our syphilis elimination initiative, and we had a 5-part strategy, which was basically built around providers, social service organizations, educational institutions, faith communities, and jails and prisons. We celebrated the fact that we drove our numbers down in Nashville, but we do know statistically that the greatest factor was none of those things which we would like to think, because most of us represent the first 4. The thing that really helped us more than anything was jails and prisons. Because it turned out by testing, So then the issue ends up being who ended up being disproportionately the persons who, showed up in jails and prisons. So as you talk about the interrelatedness of these things, I know a lot of you in this community are now involved in the mass incarceration issue, and a lot of you have read Michelle Alexander's book, and are now appreciative of the fact that what we do in jails and prisons is directly impacting health and the like. It's certainly the case with infectious disease and the things that we spend a lot of time doing. But personally, I will tell you that we did a lot of, and this is not at all an accusation in terms of this body here, but let me tell you, I spent a lot of years doing what I call drive-bys. Summits, conferences, symposia, all kinds of names they give them. And they're events where people show up for the day, and then it's hard to figure out how you capture the energy to take it forward. Now, I'm sure that you already have an agenda at Robert Wood Johnson that is going to help us make sure that we have the follow-through. But what my experience has been is that when we've tried to do capacity building in cities across this country, in faith communities, we generally have to go into communities and figure out how to work in a face-to-face, hands-on way, anywhere from 12 to 24, months, 1 to 2 years, creating the relationships. So every day that we work on cementing meaningful relationships with people in and around communities that are being most disproportionately impacted, it's an important step forward, because the digital divide is real. My assistant Cynthia is sitting back there, and she's a digital person. She's into it, right? But the other night we were trying to get some information out in our congregation. This is our congregation where we think we have the sophistication. We found out in our congregation we have a tremendous digital divide. But that's what happens if you're talking about serving sectors of the community that end up being void of the kind of teaching learning experiences that have brought them to the place where they are literate and comfortable with the technology of the day.
Ms. Perez, can you respond to that, particularly engaging the Hispanic Latino communities?
Sure. I think, the boots on the ground. There's no easier, or there's no shortcut, but really, getting out into the community and knocking on doors and picking a neighborhood and being like, okay, I'm gonna meet some folks here and I'm gonna listen. I think that's the hardest thing. As community leaders or people with resources, we're like, oh, we have so much stuff for you. You should do this. 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 And the reality of it is that people who are living under this oppression we are told what to do all the time. We are given orders and given orders and given orders. But going out there with an ear and listening and hearing what people are saying, and then be like, okay, we have options, and these might be helpful to you. But it is hard. It's hard, just going out there, knocking on doors, getting a couple of community members involved, barbecues. 4th of July, oh my God, I'm so ready to hit the community on 4th of July. I know everyone's gonna be out barbecuing and be like, hey, let me tell you about the work we're doing, you know, because that's where people are. Going to them is hard, but it's beautiful, and that's our community, so.
It's more of a response, actually. You had asked what we thought might have been missing. And so, representing the National Alliance on Mental Illness for Davidson County, one of the things that I see missing is I hear some reference to mental health, but very little. And I don't hear any reference to it in behavioral screenings and prevention. And we know that a lot of hospital beds and a lot of medical care is given over to the costs that come as a byproduct of mental health issues. And those mental health issues cause secondary, comorbid conditions. So I think, one of the things we need to look at is that, and only just now heard the prisons being brought up. And we know that's the #1 place for mental health care in the whole country. And so I really do think it's something that we need to continue to bring into the conversation. I know there are things being done here that are looking at mental health parity, and we need to continue that. But again, you brought in the homeless population, and there's a lot of folks out there involved in that, and those same folks are folks that end up in the jails instead of into care. So I just wanted to bring that forth as something that I felt we were missing.
I see Tracy and Amanda smiling back there because I think mental illness is going to be one of the issues that's going to be discussed at the next summit. Mental wellness. So, I'm sorry, mental wellness, but behaviors. So I think we also have another volunteer for the planning committee right here. So make sure you grab her name. We have someone right over here.
Hi. One of the things I think there was an implied talking about communities. It was really I was talking about place and talking about different types of people. One of the things that that we need to, that I think we need to deal with in this country in a better way is gender. And that women of all incomes, of all races, of all incomes, suffer systematic disadvantages. And public health, I think, and health equity has been slow to embrace gender, all because women are the majority of the population, but they still are much more at risk for violence, lack of access to resources, or having systems and opportunities that are designed from a male paradigm. And what, in terms of advancing health equity, I think it's easy to go to, we think about poverty and race, but we don't necessarily explicitly talk about and come up with things around gender. And I would wonder, what do you think we can do in this community to advance that?
What can we do to advance gender issues? Yes, Ms. Perez?
Yeah, I think that's I think, like you said, it's not an issue that's just here. It's an issue of everywhere, and to me, it goes into like where are we having these conversations and how are we having them? Are we having it at a time where like working mothers are picking up their kids from school, and trying to get them to meet us somewhere, or are we trying to have these hard, difficult conversations maybe in the school, right after they pick up their children? I think it has to be driven with a level of intentionality that if women's voices are not participating, then maybe that conversation does not need to be happening at that point, It's like, okay, we are missing some important players in here. we need to find them, and not to continue. Because sometimes I think we get into the rush of things, so we got to get things done, we have deadlines, we have things, but it's about, ultimately, it's like about what we're doing or how we're doing it, right? And to me, like gender and gender balance comes into how we are doing things, and who are we pulling through it. That's my view on that. I came from my own experience with Workers' Dignity is when I applied, I was a former grocery worker, and before that I was a hostess at a restaurant. And even like my own experience of applying for this position, I didn't feel qualified. I was like, I'm not qualified. There's wonderful people with education that could do this job, So it's not even about just like opening doors, It's about opening doors, going out there, shaking somebody's hand, and saying, "Hey, you should be here. This is for you." We don't want this to happen without you, and I think that's how my own experience has been, and my own experience and how I feel comfortable speaking to you all here. Because years ago, I was bagging groceries for some folks in this building.
So I know we have people in the audience that are somewhat experts on the issue of women and children. We know that in order to take care of our families, a lot of times it starts with the women, it starts with the moms. So I'm wondering, Dr. Kim, would you like to respond since you have a microphone in your hand?
Okay, as long as I give my comment and my question afterwards.
Oh, yes, okay. We have a couple more, we'll go for about 5 more minutes and then we'll wrap up.
Well, I think one of the main issues is it's the whole issue of equity and having voice. And we know that women really control healthcare in the family, but yet we tend to ignore women and women's voices when we're trying to make the community healthy. So I think it's a paradigm shift as far as where we allocate our resources. We tend to focus a lot of public health programs on women, but it's not necessarily looking at how do we listen to the women and put them in the places of power. It's how do we as public health people save the women and give them the information that we tend to think that they need to do what we want them to do, instead of listening to what is it that they need to do to strive. And I think it's that kind of a paradigm shift of stop coming and saying, I'm the public health, I'm here to help you, to I'm here to listen to you. And I think that would help that conversation.
That's often what I refer to as the missionary mentality, where we come to save you and to tell you what we need. And in many instances, the people who design those strategies are not women. And we do know. Well, go ahead and say it.
We want to hear.
So, but I just wanted to, you asked what was, can I do my question now?
Yes, go ahead.
We said what was missing from the panel or so, and I thank you all because it was wonderful information and I enjoyed it. But there needed to be one more seat there, because as long as we always put health equity in the frame of people of color without having a white person up there, we lose that voice. Because then it's a bunch of people of color complaining about not having equity instead of having a conversation that includes everybody that is involved in it. And I think that's important, and I think that's a major miss there. Because even when we would call for an equity meeting and say, everybody send somebody to talk about equity, they send the black person or they send the Latina person. And we never get the whole perspective, and therefore it's never actually taken seriously. So that's my comment about who's missing or what's missing, that extra chair over there. But as far as the equity, the question is, we tend to look at equity as a pie. And everyone is okay with equity as long as it doesn't involve them giving up a piece of their pie, because it's only so much. How do we then move equity forward with working with privilege, because nobody wants to give up privilege to help somebody else?
I could expound on that for you for a while.
Reverend Sanders, could we let Dr.
let someone
Webb
else
respond first and then?
Please.
Yes.
No, go ahead.
Yeah.
Well, first, I believe that health equity is a very pervasive challenge in our community, across the country, actually. And I don't think it's something that we can slice and dice in neat little pieces. I think it's something that we have to address from a more of a broad-based perspective. I think health equity needs to be dealt with from, and the whole race issue, I tried to expound on this a little earlier. It's health equity is really not a race issue. Health equity is an issue of distribution of resources regardless, and socioeconomic status is not necessarily a race issue. So I just think that we should take a more broad-based approach to it under any circumstance and do our homework and make sure that we're dealing with it from, and I keep going back to this term, from an evidence-based perspective.
So I'm going to give you a book to read, all right?
Homework, given homework.
Mindy Fuller Love has written a book entitled Urban Alchemy. And one of the things that she talks about in that book is how these issues have developed in a fashion that even very often what we are looking at when we see in statistical terms or in health terms, if it has to do with, epidata as relates to disease, is in and of itself a construct that ends up with outcomes that's a byproduct of something that's driven by a misinformed perspective. And that's why I'm saying, as I started, that our greatest challenge in community is to figure out how we continue to push the parameters and to look for the ways in which we might discover. We have discovered that the work we do at our primary care clinic, at the First Response Center, has been most successful because we have dealt with some very basic things that are important to it. One is, for instance, in terms of adherence to HIV drugs, we do directly observed therapy. But if you want to do directly observed therapy with the people who are dealing with severe mental health issues and the people who are chronically displaced and homelessness and that kind of thing, you have to have somebody who is actually a part of that team that has the experience and the rapport with the people that you're going to, right? So one of the things that we've discovered is that by doing it that way, I mean, it would seem like that's a very simple thing. One of my favorite, writers is Langston Hughes, and my favorite Langston Hughes character is the character Simple. Sometimes we fail to reach our goals because we create complexities that are part of the mechanisms that we have developed for analysis that do not necessarily solve the problem. I say it over and over again. We've had the Minority Health Initiative for these 15 plus years now around HIV in particular, okay? And the numbers continue to grow. There's a reason for that is driven by something other than the fact we've had Debbies, we've had Ebbies, we've had every kind of project you can think of out of CDC that's supposed to respond to it. And the fact is, it is not translated into the outcomes that we were looking for. I think we can get those outcomes, but I'm agreeing with your position in terms of women. I'm agreeing with the position that you're saying in terms of those who are the disenfranchised. The reason why I use the language very carefully to say the culture of oppression is that oppression is not exclusive to something that is affecting black people. It's clearly, it's a reality for women. It's a reality for others whose life experience has put them into a stigmatized category of personhood. And that's what we're dealing with in terms of inequity.
Thank you. I think we have time for one more question. Well, okay, 1, 2, and then next. Yeah.
Yeah, Nashville for sure is a city of silos, where collective impact is almost a foreign language. How can we bring the siloed organizations together to a common table to solve these problems?
I think just oh, I'm sorry. Go ahead, and
That's a great question.
Yes.
Actually, it has to start with an assembling of the key stakeholders that, and what is a stakeholder? A stakeholder is an individual or organization that has an interest in the outcome of a certain situation. Now, it could be they don't want it to occur or they do want it to occur. Either way, that's a key stakeholder. So it has to start somewhere, and it starts with assembling key stakeholders and having that dialogue, getting to the table, and working that to a point where there's an agreement that this is indeed a social issue in our community that needs to be addressed. And that's the beginning of it. And then from there, starting to assemble resources and individuals and mindsets to create a strategic plan to move towards that goal. But first, it has to be, it's like anything else, if you're a drug addict, the first thing you've got to do is understand and agree that you are a drug addict and that you have a problem. Until we can get to that point where people are coming out of their silos and out of denial, or someone has to pull them out of it, or the situation has to get so bad, it's called, often referred to as a burning platform. You have to create the burning platform to get individuals to agree that we do have a challenge here that needs to be addressed, and only then will you start to move towards a collective impact initiative. This siloed mindset is so pervasive throughout our country, not just here, but where I came from in Memphis, it was very prevalent as well.
Thanks. I think really quickly, one example that has worked with us at the Worker Center is to work with Vanderbilt to do just a survey out into the community, to listen to people, to hear about what was happening in the workplace. And I think it's those small opportunities that build a foundation for the bigger bridges, and to connect it, right? There's the reason why, like, healthcare is not, it's, oh, well, we're a workers' organization, so we're not going to be involved in that. I think it's intentionally like reaching out to, like, okay, I'm gonna reach out to a women's rights group, right, and see how we can come together on this issue of healthcare in our community, and what's happening out there, to just like oh, it's not just the Black community issue that's dealing with this, or the Latino group is dealing with immigration only, right? I think it's those instances and those like conversations and those like summer projects. I think in order to work for the large scale like assemblies and community, we have to know each other, right? And and it starts by calling each other, because emails, man, who gets so many emails in this room? Calling each other and setting up these things where we can work together and find that middle ground.
I would say that the key to effectively working together is where my issue becomes your issue. Because until you represent the issue and the concern that I'm voicing in a room when I'm not present, will it ever be addressed effectively in a way that gets beyond the typical limitations, hetero privilege, wealth and resource, okay, ends up being very often the definers of who ends up at the table and in the conversation. And I think one of the things that we have to do is become ourselves well-informed enough, all of us in this room, that we can be representatives for each other. So I would like to think that it doesn't require having a Black person in the room. I would like to think it doesn't require having a woman in the room necessarily, but rather that any of us in the room ought to be speaking to women's issues. Any of us ought to be speaking to the issues of the Latino community. Any of us ought to be speaking to all these issues. And I think that requires what I was trying to suggest earlier, a level of growth in terms of who we are as understanding each other and our concerns.
Dr. Webb, you had a quick response.
No, I just have a shameless plug.
Go ahead.
On Saturday, June 6th, Nashville General will be, as part of its celebration of 125 years in operation, will be hosting a health fair in Hadley Park from 10 a.m. to 2 p.m. And it is a health fair with a purpose. not like you've seen before. And so show up and be prepared to be amazed.
Great.
Do we have one more statement? And then we're going to wrap it up. Okay. I would like to say thank you to our panelists. This has been a very fruitful discussion. Thank you to the audience, because your input really does matter. So thank you for those challenging questions posed to us as the planning committee for next time. So I'd like to give our panelists. And as we transition off the stage, I'm going to ask Ted Cornelius to come up for the Nash Vitality Awards.
Hello, thank you. This has been a really great discussion, and I appreciate, I know time is of value to everyone, and the fact that this amount of people are here for something like this just speaks a lot. So I just want to thank all of you for taking the time to be here today. I also wanted to say this discussion, I think this is one that we all agree, continues not only in this room, but we continue to keep having this in our different networks. And I've had the opportunity to be a part of the Healthy National Leadership Council, work alongside Dr. Paul and Dr. Batson and others. And I would say, as one of the terms that came out of that discussion was around collective impact. I work for the YMCA, but I've also been serving as the chair for the Healthy National Leadership Council, because I truly do care, as well as everyone who serves on that council, about things like this and other health priorities for the city of Nashville. And the one thing that I'm proud to join a group like this is that we have a statement that Dr. Paul mentioned. It's been the vision, which is, I'm just going to read it again. It's a healthy Nashville has a culture of well-being where all people have the opportunity and support to thrive and prosper. And that's been one that we all agreed as a vision to strive towards. Now, we're not there yet, obviously, but it's one that as we continue to keep coming together and we continue to keep having this discussion, that keeps driving us to try to work through some of these different things. And it is only through a collective impact strategy to where we bring a lot of different lenses into the room that we can contribute to this. And I would say, I know I carry this when I come to each meeting, and I'm sure the others do as well, but we are coming on behalf of all of those that we know are in the city of Nashville that reside in some way. So it's an honor to be a part of this group, and a real privilege. And so I just wanted to, I know there's several of the Healthy National Leadership Council group that's here. In fact, would you mind standing? I know this is not planned, but I'd love for you to stand just so that some of the people can see who serves on this group, for those who are here. So yeah, please give them a hand. Thank you, and thank you for your time. It's been great. So, well, I have the opportunity to talk about, there are some awards, and this is a difficult one because there is so many great, tremendous leaders, tremendous organizations in the city of Nashville that are really striving to do exactly what we're talking about. And it's hard work. It's really hard work. And I kind of go back to Reverend Sanders. He talked about the business of stretching. And I would say, as I mentioned some of these groups, they're absolutely demonstrating stretching to places in order to be able to move some of these different things. So I have the privilege of talking about some of these awards and who's going to be a part of these. So I'm going to follow the agenda, and we're going to talk about the Leadership Award. And just to explain the Leadership Award, it's a truly outstanding contribution through systems and environmental community changes to improve the health status of individuals, targeted groups, communities, or the nation using a health equity lens. And so I'd like to ask Walter Davis and Susan Veal to come up to the stage, please. Okay, great. So as they're coming up, I'm gonna talk a little bit about as they come up to accept the Leadership Award. They're with the Tennessee Healthcare Campaign. And just to describe what that is, the Tennessee Healthcare Campaign, it's the state's premier nonprofit consumer healthcare advocacy group and a leader in the healthcare justice movement. The mission for everyone to have guaranteed affordable choices in healthcare began in 1989. They envision a society where the physical, mental, and emotional health needs of all adults and children are met. And the board of directors consists of consumers, advocates, and social service professionals from throughout the state. And the THCC works in collaboration with advocacy groups, affected constituents, community leaders, and policymakers. And they are to influence positive change in public health and healthcare. And I'd like for you to give me a round of applause for them as they accept the Leadership Award. Thank you. And I think we're going to have a photographer come up here and take a photo. Is that correct? Okay.
While they're doing that, this is Jackie Schrago, who's done such an amazing job organizing volunteers in Davidson County, Wilson County. Frida Player is our president, and Sydney Sydney's is secretary. Our assistant director, Susan Beal, and Kathleen Jones of our board of directors as well. And I'm Walter Davis.
Tennessee Healthcare Campaign is a quiet little organization probably most of you have not heard of. But for the 100 volunteers who are privileged to be boots on the ground, delivering the face-to-face assistance that our panel talked about, we have worked to enroll people in the Affordable Care Act. And any of you who would like to volunteer, even for a few hours a week, for the 10 to 12 weeks a year where we do a great deal of the work, we need everybody we can get. So call on us.
Just thank you, Natural Vitality, for doing this. We really appreciate it. And really, the volunteers, I have to recognize them. They do all the work to make the organization look good, really on the grassroots level, making sure everybody has access to quality health care.
And I would just add, we're not giving up on Insure Tennessee. We're building a network across the state.
Thank you. Thank you for being here. I appreciate it. Congratulations. Okay, thank you. We're going to go on to the second award, and the second award is called the Innovator Award. And this represents an individual or organization that has orchestrated an influential, innovative approach to advancement of equity in health and well-being. So accepting this award is Raleigh Fatuki. If you wouldn't mind coming up, please. Yeah, give them a hand. So as they're coming up, I'm going to talk about, they represent the Meharry 12th South Clinic. And just to describe the 12th South Clinic, I know many of you are familiar with this. The Meharry 12th South Community Clinic is a student-run free clinic under the supervision of faculty physicians at Meharry Medical College. It was founded by Meharry students and established in partnership with the United Neighborhoods Health Services Clinic Network. Its mission is to address healthcare disparities within our community by providing free, high-quality care to Nashville's underserved populations and by serving as a clinical skills training ground for students, inspiring the next generation of primary care specialists. Services include free primary care and after-hours access to care. Meharry 12th South Community Clinic serves to both enrich the educational experiences of students and provide top-quality health care at no cost to an underserved community. And this community clinic is made possible by the dedicated student and faculty volunteers at Meharry, as well as donors and institutional support. If you wouldn't mind, give me another round of applause for that.
Thank you. Hello, everyone. My name is Raleigh Fatoki. I'm a second-year medical student at Meharry Medical College. I just want to say thank you for this award. This is further validation of the work we're doing in the community, and I can't express how much it means to us just to... Oh, I'm sorry. I can't express how much it means to us just to get this support from the community, just to know that people are paying attention to the work we're doing. It's not going unnoticed. I just wanted to give a few thank yous to our student volunteers as well as the faculty volunteers. We know it's hard after a long day of work or a long day of class to come in to the free clinic on Thursday evenings, and sometimes we stay as late as 10 or 11 p.m. at night, and this is after a full work day. So we really appreciate all of our volunteers as well as the faculty, because no one's getting compensated, but this is furthering the mission of our school and providing more training to the students. We're open every Thursday evening at United Neighborhood Health's Waverly Clinic on 12th Avenue South. And one thing we say to people when we talk about the clinic is that you may have insurance, you may not need free health care, but you know someone who does. And so we invite you to bring them to our clinic or refer them to our clinic. We're open every Thursday night starting at 6 p.m. It's totally free. We cover diagnostic labs, all the medical care, and we make sure that they get the care that they need. So if there's a referral, if they need to go to Metro General or see a specialist, we're their primary care home, and we make sure we get the care that they deserve. But just a few thank yous, because majority of our funding comes from philanthropic grants and donations, over 95%. So I did want to acknowledge some of our major donors. And they include the Community Foundation of Middle Tennessee, Piedmont Natural Gas, the Temple Congregation, Ojibwe Shalom, as well as United Methodist Church Black College Fund. And I also want to acknowledge two of our primary advisors, Dr. James Sullivan in internal medicine at Meharry, as well as Ms. Karen Burson in the Office of Institutional Advancement. But again, thank you so much for this award. We really appreciate it. And it's just given us more motivation to continue the work that we've begun. Thank you.
These pictures are very important, by the way, so we're going to pause for those. So thank you very much. Okay. Okay, we're going to move on to the last award, and this award is titled the Pioneer Award. And a Pioneer Award is for recognizing significant lifetime contributions and service to advancing equity and health and well-being. And accepting this award is Reverend Sanders. So if you wouldn't mind coming to the stage. And yes, let's give him a hand, please. So as Reverend Sanders comes to the stage, I'm going to talk, even though we've had an introduction with him, I'm going to talk a little bit about some of his work. So Reverend Sanders, as you know, is a senior servant and founder of the Metropolitan Interdenominational Church in Nashville, Tennessee. This congregation has attracted a broad cross-section of people with the mission of being inclusive of all and alienating to none. Metropolitan has outreach ministries in the areas of substance abuse, advocacy for children, sexual violence, and harm reduction, in addition to providing services to persons affected with and affected by HIV and AIDS through the First Response Center founded by Reverend Sanders in 1992. He also holds a life membership with the NAACP and is a member of the Interdenominational Ministers Fellowship. He's been the former president, and he is a former member of the Alcohol and Drug Council of Middle Tennessee, has served as a commissioner for the Tennessee Human Rights Commission. He is a past chairperson of the Ryan White Community AIDS Partnership and is still an active member of the consortium. He was appointed to the CDC Advisory Committee on HIV and STD Prevention during the Clinton administration and served 5 years on the Presidential Advisory Council on HIV and AIDS during the Bush administration. And in 2015, he was appointed to the President's Emergency Plan for AIDS Relief Scientific Advisory Board. And Reverend Sanders has been the recipient of more than 100 honors and awards from religious, political, academic, healthcare, and social service organizations, including more recently the National Newspaper Publishers Association Humanitarian Award and the American Civil Liberties Union of Tennessee Lifetime Achievement Award. If you would please give me another round of applause for Reverend Sanders.
Congratulations. These Lifetime Achievement Awards are starting to make me think that it has something to do with the color of my hair over the years. But I do appreciate the fact that, and I'm honored. I think the only thing I want to say to you is that I never receive any award when I don't acknowledge the fact that everything I do is the byproduct of the support of the Metropolitan Interdenominational Church. We do work all over the world. We've been blessed to go lots of places and do lots of things. But I try to always make sure that there's a little church on the side of the hill in Nashville on 11th Avenue North that where there are about 350 people who actually end up being the foundation of everything that we do. I just happen to be the face, but the fact is, it's each and every one of those persons, some of whom are in this room and some of whom whose voices you've already heard here today. So I'm just very thankful for that. And then I never accept an award also without making reference to my better three quarters, who many of you know me by. You probably know me better as Billy's husband, over against being, you know, the senior servant of Metropolitan. And Billy's out there. Wave your hand, Billy. Amen. But this work does not happen unless you have the support of lots of people, and particularly, as I said, my better three quarters. She went past being better half a long time ago, and I'm always very thankful for her presence and for all of you who continue to be willing to hear my voice and to appreciate our work. I know sometimes it's in your face, and sometimes it might be less than easy to hear, but I think our intention is to make sure that the conversation continues to grow, expand, and to eventually and ultimately address these issues that we're here today to talk about. So I thank all of you for being here and for being a part of this conversation, because I believe in conversations as the way in which transformation and change happens. Thank you. And also, access issues, we need to add another step. I'm here to do a hip replacement operation, so it's all right coming up, but going down, I have to go this way. Thank you.
All right, Tanae?
Okay, with the next two panels come up here, we're going to push lunch back to 3 o'clock today. So this is an opportunity for us to network as we transition to the next room. Right outside of this room are our box lunches. They're on 3 tables in alphabetical order, so you placed your order when you RSVP'd for this event. And Tracy, Amanda, for those that didn't RSVP, are there... Come see Amanda, who's waving her arms in the back if you did not RSVP and select a lunch. So at this time, I'm going to release you to transition, grab your lunch, transition to the next room, and we're going to be over there for the rest of the afternoon. Thank you. Good afternoon. We're going to go ahead and move to the next segment of our day. While we're finishing up our lunches, we have an opportunity to hear from Dr. Thomas Trudeau, who is the Director of Epidemiology at the Metro Public Health Department. Metro Nashville Public Health Department. And she's going to provide us with the Equity Atlas presentation. So Dr. Thomas Trudeau, would you like to come on up?
Thank you very much. The Equity Atlas, building on some of the themes, this will be mostly a demonstration, and you will get cards with a link to this website. But building on some of the themes that we heard this morning about having evidence base, being able to sort of stretch our boundaries and stretch the parameters of conversations. The Equity Atlas is an opportunity to look at indicators and build a model not just from a health standpoint, from a social and economic standpoint on equity and the benefits of equity and the benefits of improved equity. And it provides national data, and in certain cases it also provides local data, and so we can, for example, compare ourselves on some of the indicators to the U.S. Since there are some of the local indicators, it is a work in progress. It is an evolving website. So I will, for the sake of time and simplicity, focus mostly on the indicators at the national level, but you can see what's available, and then you can also explore and see which indicators are available locally and how you can compare that to the nation. Look at indicators. Left-handed. So part of this is sometimes we think very abstractly, and this really builds the case. For example, in this about growth, is that most of the growth of the United States has been people of color. And it builds a case that in terms of equity, that if you have systematic disadvantages, well, most of the people that, for example, Nashville will become a majority, minority, county in the next, 15 years. And so, if you are systematically excluding the majority of your workforce, then you really suffer serious productivity issues. It's serious justice and productivity issues. So it's not even an abstract that, well, different people should be treated differently because of minority. Actually, minorities will become a majority and are driving growth, are driving the growth in areas. Otherwise, we would be like some of the countries in Europe that are actually losing population. So this presents, data on that. And as you can see in the long term that where we're at with 20 to 2010s, almost all people of color that are contributing to the growth of the population as compared to 1980 to 1990. Even then it was more, but it's just become more and more pronounced. So so it just drives home the fact that this is a practical matter, not just a theoretical matter. Another indicator that is used is looking at the economic impacts of inequity and looking at increasing income disparity. So 20% so in the United States, 20% of households have an income below $20,000. And the top 5% have an income over $180,000. And that this figure, and they have trend data, and that this has actually grown over time. So once again, this makes it in terms of trying to deal with making an economic case and making a case for policymakers. These are the types of drivers that would start different types of conversations with policymakers versus just ethical or moral, that these are actually practical, that 20, and then also in terms of, for those of us who are in public, a nonprofit sector, 20%, and it doesn't seem necessarily fair for us to, that government alone can't sort of, subsidize 20% of the population.
Why did they choose those percentiles? Why not the top 20% and the bottom 20%?
I think it's because it's a very skewed distribution, that a lot of people are at the bottom, and then a very few people are at that top. That there's a very small, skinny tail, and the distribution is not evenly distributed. So there are a lot more people who are towards the bottom than there are people towards the top. So they're looking at sort of concentration of wealth. And this also ties into some of the things that we were talking about. And this is so this is data that includes our jobless economic recovery. Low wage jobs. That this points to percentage of people just people of color are more likely to make less than $15 an hour, which is what's currently being proposed as a living wage. And like nearly 2/3 of non-Hispanic whites and less than 60% of people of color, and that hasn't changed. And actually the gap has widened. So it's once again the issue of economic equity, and that without, and as we've heard this morning, without economic equity, there really can't be health equity. And they have data on this that can compare this in Nashville compared to the United States. This also points to the larger issue whereby, as you can see, jobs have grown, the GDP has grown a lot more than jobs. So it's grown nearly twice the rate than job growth. And this is once again during and post recession. So this is recovery, and you would expect that this to go up, so that it points out to the fact that there is increasing maldistribution of resources. And when you look at some of those other ones, like the rate of people making less than $15 an hour, what we would consider a living wage, that macroeconomy, that there are large societal forces that are creating maldistribution of resources, and and without addressing those, we are likely, if people are living on less than 20% of people are living on less than $20,000 a year, it is families that it is very unlikely that they're going to be able to make the investments in health that we would consider for them to have equal access to to maximum health.
So I just wanted to, while Dr. Thomas Trudeau is moving to the next slide, this data helps reinforce the conversation this morning, the points that Dr. Webb brought up about being able to have this data. This data is available, Dr. Thomas Trudeau, at the what website? Is it the National Equity Atlas.org?
Yes.
Okay. All right. So that it's available for us to go to, so we can examine the numbers from different perspectives. So we have time for maybe just a couple more minutes, and then we'll move on to the next. But there you go.
Another thing in terms of the economic benefits are that looking at current educational attainment, that in relationship to what future job needs are, that there is an education gap, and it does it by ethnicity. So about equal access to educational opportunities. Economic equity and educational opportunity are inseparable from health equity. But in terms of getting conversations going with policymakers, that these are some of the issues that it's available, it's accessible, and it will draw in these benefits, as well as it will draw in this part of the conversation and help people engage. And then you can engage how, like, having housing burden is related to, poor health. So, so it's really good to sort of be able to sit down, take this website and sit down and start having conversations. But it's not all bad news. I wanted to point out one thing that it does do. One of the things that this website also does have policy recommendations that you can explore. It has examples of some best practices, and it also sums up the benefit, because sometimes we get focused on deficits, but also what is the benefit of equity? So this shows like over, that, we would have like close to a 20% gain in gross domestic product if everyone were paid equitably. And so you can see that it's not just a matter of ethical, but if you have people who are like, well, equity is too expensive, equity is too that, you can see they've done calculations, and they can do these calculations locally too, where you can see and you can monetize, like we did with in the equity report about monetizing the benefits of walking and of better of active transit infrastructure. You can also monetize the GDP and other gains of improving equity. So this website contains a lot of economic information. There are several health indicators on there as well. But you can use this website to work with people to make the economic case, and then that will really help bolster the health case for equity, and also demonstrates how these levels of educational access, wage access, income equity, housing equity, how all these things are intertwined, and then that helps us build the pieces of the puzzle in order to help move change. So it's a very interesting website. There are local data available for many of these indicators with comparisons to the US. So I hope that you will take a chance to explore it, and I hope that you'll find it useful when you're trying to explore and build conversations to explore these issues.
Hold on. Thank you, Dr. Thomas Trudeau. Do we have time for maybe one question? Do we have one question from the audience, or a question or a comment, maybe? Yes.
I had a question about, you said that 20% of the population is making less than $20,000 a year. Is that for a family or individual?
That was for family. So 20% of families are less, or have less than 20,000. The bottom 20% has incomes less than 20,000 a year. Oh, and one thing I didn't show the slide, but is talking about that this isn't just about poverty, that when looking at educational levels, this is actually one of the things that shows that even for every educational level, that there is a penalty for being a minority, an ethnic minority, in terms of your median wage. So, so that we have to have these conversations across all levels. When you see that, it's not just, oh, it's just the poor people. It's like every that we're totally dampening our economy and our vibrancy and our growth by suppressing certain groups of people. And it's very pervasive, so.
I think when it comes to messaging and how do we convince other people that equity is important, these numbers right here, looking at the gross domestic product, it's a win-win for everyone. Thank you so much for your presentation. NationalEquityAtlas.org, so everyone jot that down. We're going to go ahead, and I think, Amanda, it's time to transition to the next session. So we're going to take maybe about 5 minutes to clear your tables, throw away your trash, maybe get a restroom break. Amanda, where are the dots that people are going to get for the breakout discussions? Okay, all right. So in about 5 minutes, we'll reconvene in this room right here, and we'll move on to the breakout discussions this afternoon.
Where are the yellow tables? Only one yellow table? I mean, one yellow group? What color is that? They are. They're too expansive. Do you want to form 2 yellow groups with 2 tables each? We can pull one of these tables right here. And where are the reds? come we have so many reds? You guys feel like you're overwhelmed? Are you comfortable with that?
No, it's not going to.
Okay, that's fine. Yes, reds. We need some red volunteers to come over and join the blues. It won't cost you anything. Some blues need to, some reds need to join the blues. Some more reds need to join. Do you know, are there something wrong with the blues? Are you still all from the same? How did you guys all get blue? The random choice for the dots.
Did you all get
And you all came up with blue?
How about that?
Oh my God.
I think you lost control.
Who had control? A couple of you could come over here to this yellow table. Maybe you have most of the people in the whole room. We have a lot, yeah. You've infected the whole room. That's right. In a good way. Okay, look at your groups. We tried to do this randomly by closing your eyes and drawing a dot, but I see that the blue table up here is made of one entire family. Are you finding that at the other tables, or do you have strangers with you? I mean, you should. We want to have a mix. That's what we're going for. Nobody's saying. Okay. Amanda, anything else? Okay. Where is, for the next 2 hours, we're going to be working on the 5 strategic questions that were brought out earlier this morning, but they probably didn't say these are strategic questions. Just a little introduction. I would like to introduce John Stachel. Colonel Stachel, do you want to say something about yourself?
I'll say a little bit. Hello, everyone. I am to be known as the paper boy. I will distribute paper whenever you need it. It's great to have everybody here giving their opinions and discussion on such a fantastic, critical subject, and we really appreciate what you're doing, and hopefully we'll come out with an excellent product that'll give us a lot of good ideas on making solutions. That'll be it.
Okay, John and I'm Tom Contop. We're with Walden University, and we reside in eastern Tennessee. I'm not from Tennessee. I've only lived here 35 years. When I got here, someone told me you have to be here 50 years before you could call yourself a Tennessean, so I'm still working on that. One of our significant parts of our mission is influencing and helping positive social change. So we're very interested in helping work here, and our job is not as experts, but to help you keep moving in the right direction for the next 2 hours. I'm a psychologist. I started off in healthcare. I'm an organizational psychologist now. I don't work with people who have issues. Is anybody in here without issues? Yeah, you all have issues, right? Okay, now, just as an overview, we've formed our small groups. Each table or each group needs to have a spokesperson and at least one recorder. And the spokesperson is going to represent you by giving us some feedback as we go through this session. You can talk amongst yourselves in a minute about those different roles. Because we want to try and make sure we have accurate information that we're collecting, the recorders, if you could, indicate your name and a phone number, because we're going to collect the papers from you, and there may be things we just can't figure out as we read those. And this is not public information. This is just for this activity, and all names and numbers will be destroyed, right? Who can guarantee that? Okay, Amanda, she's going to guarantee it. Thank you. All right. Any questions about the general process here? We're going to have some ground rules. I'm not going to read these to you, but if you could just quickly scan them. The whole purpose is we want to have shared input, information. We want individuals to provide ideas as much as possible, but because we have a lot of ground to cover, we may not be able to get everybody to be able to say everything they want. Feel free to put your information down on a piece of paper and include it in the session as we conclude. We'll be going around and we'll give you some kind of input saying like 2 minutes left in this activity, so try and wrap it up, then we'll go to the next thing and so on. If you have any questions as you go through this process of us or others, make sure you get those answered. Any questions about ground rules? Okay. Think about now who's going to be your recorder and who's going to be your speaker. Talk amongst yourselves. We need about 10 to 12 minutes per question. So could you help me a timer? Sure. Okay, I see one group in the back, they're arm wrestling. Another group, they're drawing straws. Have you got your spokesperson and recorder? Okay, good deal. Okay, what we're going to do, we're going to present to you 5 questions. We're going to do 1 question at a time, so you have about 10 or 12 minutes to address those collectively.
Ideas on the paper.
And I noticed some of you have little sheets of paper that you want to take notes on. That's fine. But when it comes down to a final answer for each group, we'd like to record that on a large sheet of paper, okay? Now, there are 3 basic things that make up what's going on here. We've talked already about the 2015 report, and we had a good discussion this morning. Out of that, a group of individuals decided there are 5 strategic questions that we need further clarification on. And that's what your role is going to be this afternoon, to try and provide some input on those 5 questions. Based on your input, then there's going to be a supplemental report that is pulled together, and it will just be augmenting the main report. So in terms of the final product, that's kind of a vision of what's going to happen. So you're going to be instrumental in helping put together further information and answer some of the issues. Any questions about that? Okay. Because we have 5 questions, we're going to give you about 10 to 12 minutes per question with some discussion. And that'll take us maybe into the 2nd hour. And then we're going to report out and talk about what some of the issues are to try and get some collective perspective. You ready? All right. Question 1. We're interested in finding out what you think the definition of health equity in Nashville is. So that's question 1. You can begin working on that, and we'll be back in about maybe 5 to 15 minutes. On everybody's shoulders to get everyone in your group involved. If someone doesn't seem to be providing, ask them, hey, what do you think about this? Okay? So try and get everyone. Question 2. What areas are missing from the report that need to be addressed? And now, that's back there. Okay. You got 12 minutes for discussion. And again, you can have a news spokesperson or recorder. It's up to you. Number 3, what are the priorities we need to set in Nashville when it comes to health equity based on the 2015 report? Okay, you have 12 minutes. Break. We're going to get into the 4th question. If you need to get up, stretch, do it at that time. In fact, you might want to stand up and do the 4th question, depending on how your knees are. Number 4, what are specific policies or programs we can implement over time to address these inequalities? Now we're referring back. Are there any local programs or policies that are successful in addressing health inequities that could be easily replicated? I know some of this has come out before, so it shouldn't be too much of a challenge. Contact me. There are a couple of cards up there. I'd be happy to direct you in the right place for that. We have a final thing coming up, but I wanted to close with something. We didn't talk about creativity and differences within the teams, but I think you really worked well together, so I was impressed with that. How many left-handed people do we have in the room? Not many. Okay, because we talk about creativity as being one side of the brain versus another. How many, do you know your eye dominance, left or right? A simple test for this, some of you do. Extend your hand, make a circle, look at an object through the circle, and close an eye. If you're still looking at the object, you're looking at it with your dominant eye. If it's shifted, it's a non-dominant. Now, if you're right-handed, is your eye dominance the same? Yes. No. If it isn't, then see, you're a little more divergent in thinking, too. I didn't say more accurate, a little more divergent. Okay, similar exercise. There are 2 things I want you to do. This will be the last thing. You have to do 2 things. Do exactly as I tell you to do, or ask you to do, and don't take your eyes off of me. You have to look at me and listen to me. Make the circle again. You don't have to look at me through the circle, but just look at me with the circle and do what I say. I want you to slowly bring your hand toward your face. Don't hit your neighbor. Slowly bring your hand to your face. Keep your eyes on me. When your hand's about 6 inches from your face, quickly put it on your chin. 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 On your chin. On your chin. Hey, what's this? Okay. You've been here too long. You are tired. What's the moral of that story? Because you've done a lot of talking. You've come up with a lot of stuff. What counts is the action. People want to see what you can do, not just what you say. And they'll be looking at you to do things. So I encourage you. The colonel said to me, this group is the most highly involved and energetic group I've seen ever. And he's been to war. So you guys ought to think about a second career in the military. Anyway, any final questions? Any problems or complaints? If so, Amanda, Tracy? Oh, yes.
What's the time frame on all of this again? I know you told us that this is going to be incorporated.
I don't think we discussed a time frame. Do we know a time frame for taking this material together? And
our planning committee for the Healthy Nashville Summit is going to collate all of the, don't throw away any of those papers that you worked on, because our group is going to work with those to come up with a secondary report that's going to go out with you, that's going to go out to you, just like the first report did. We do not have a timeline for that yet, but this, all of this information you've been working on will be going into another report.
okay, thank you very much. Give yourselves a round of applause. You did a fantastic job. And I'm turning it over to our... Thank you.
Good afternoon, everyone. Hopefully you've had a wonderful day. Did you enjoy the summit? Let me start again. Did you enjoy the summit? Great. You know, there were many highlights, and I want to say that the one highlight that I had was watching my former student, Mark Lawless, stand up several times and present to the group. And hopefully he has an appreciation of all the public speaking assignments that I gave. I'd also like to begin by thanking Attorney Cole, John Vick, and Dr. Thomas Trevor. Could you stand up, please, and be recognized? Thank you. Also like to thank the Planning Committee. Can the Planning Committees please rise and be acknowledged? And special thanks also to the work that Meharry Medical College, the students at the Meharry 12 South Clinic, Tennessee Healthcare Campaign, and Reverend Edwin Sanders. Let's give them a round of applause. Now, today is a very important time in the progressive movement in the city of Nashville, but I want to ask each and every one of you a particular question. We call Nashville the IT city. But can Nashville truly be the IT city with the lingering issues of health equity? I don't say this as an admonishment or to criticize those that tout this slogan. I think it is a very catchy slogan, but I truly think that we need to focus on health equity. And I merely want to point out that as we move up the ladder in the tier of a first-class city, that we must find solutions to improve the health equity of our citizenry. Now, Reverend Sanders talks about a culture of humility. Are we truly ready for a culture of humility? Now, with the major economic development push and our critical focus on education here in Nashville, we need to focus and become truly, truly specialized in health equity. This should be our call to action. Now, this is not a special initiative or a project. It is a movement that must traverse our communities. Now, Dr. Webb talked about that we don't have a scarcity of resources. We have a scarcity of collaboration. And are we truly ready to collaborate? Now, we must all be committed to the recommendations today of the deliberative dialogue, and I want to thank our facilitators for their great work that they've done. And I'd like to leave you with this quote by Mark Sanborn, who said, "Intention without action is only a dream. In the end, isn't what you want to do or plan to do, but what you actually do that makes a difference." So let's all go forth and lead this cause. Thank you.